Good afternoon, everyone. Welcome to the Heartland Telehealth Resource Center, Oklahoma State University Center for Health Sciences, and Missouri Telehealth Network Telemedicine Echo. My name is Haley Bell. I'm the program coordinator of the Heartland Telehealth Resource Center, and I have the privilege of moderating today's session. I'd like to start out with introducing our hub team members. So I'll go ahead and start with Dr. Molly Brown and let her introduce herself, and then we'll kind of go around with the group.
Good afternoon, everybody. Thank you for joining. We have a very robust presentation today. I am Molly Brown. I am the director of the Heartland Telehealth Resource Center and part of the coordinating team for these echoes. I will now pass it to Dan.
Good afternoon. I'm Dan Lund with Missouri Telehealth Network. I am senior program manager for grants here at Missouri Telehealth Network.
We can pass it to Dina. Dr. Wheeler.
Hi, everyone. Dina Wheeler. I'm the executive director for the OSU Center for Rural Health, located at the Oklahoma State University Center for Health Sciences campus.
And we can wrap up with Haley Bell.
Yeah, so as mentioned earlier, I'm the program coordinator here with the Heartland Telehealth Resource Center. And we will refrain from having our participants introduce themselves today, just so we have enough time for discussion following the lecture. If just a few announcements to run through before we get started with our speaker today. For a more collegial environment, we are going to use first names during the session, so it's helpful if you could make sure that your Zoom profile has your updated first name on it. The session is being recorded, and all materials, including the slides, will be shared following each echo. Please be conscious of confidential and protected health information during discussion, and please use the chat box for any questions you have, or use the raise hand function on Zoom to share any comments or questions that may come up. The goal of our Echo series is to facilitate collaborative learning and knowledge exchange among healthcare professionals to optimize telehealth delivery and improve patient outcomes. Our focus is to bring practical learning and case examples along with building networks to share information. As part of our series, I have the pleasure of introducing our presenter today, Richelle Marting. Richelle is an attorney, registered health information administrator, and certified coder who focuses on healthcare coding, billing, and reimbursement issues. She has served as an in-house outpatient multi-specialty surgery coder, a hospital-based outpatient coder, and a compliance coordinator for a large multi-specialty medical group. Richelle is also the acting director of managed care contracting for North Kansas City Hospital and Meritus Health Corporation. She serves on the American Health Information Management Association Policy and Advocacy Committee, American Hospital Association Payer Accountability Work Group, and the American College of Physician Advisors Government Advocacy Committee, where she acts as a liaison between the provider community and the policymakers on topics including telehealth. So I'm going to go ahead and pass it over to Richelle.
Thank you, Haley. A lot of these professional associations and the councils and committees that I've gotten involved with have been relatively recent, and thanks in part to Heartland Telehealth Resource Center and a lot of the education that we provide here that has really, through the technical assistance and the requests that you all submit, helped facilitate discussion on broader policy topics. And of course, telehealth is one of those that continues to evolve and change. And I expect even that in the next couple of weeks, as we start to see Medicare telehealth policies shape for 2025 and beyond, we'll see even more. So we talk a lot in these sessions and the various webinar sessions about different policy topics with telehealth, different coding and billing nuances. And the session today is really designed to pull all of those together into just a discussion on billing practices. This certainly applies to telehealth, but it can apply more broadly within your organization, your clinic, your facility, whatever type of practice or provider entity billing that you have. You can apply these same concepts across the board. And we want to go through kind of all of the different phases of the billing process and where there are common procedural missteps that eventually can affect whether and how you bill and receive payment for your services. And we all have heard the phrase probably, no margin, no mission. And that's really what this is designed to do, to help identify potential gaps, talk about specific examples and projects that have targeted some of these areas of the billing practice to actually transform and make real improvements in coding, billing, and collection of reimbursement so that organizations can move on with their mission and make services more widely available and accessible. So I want to go through kind of the assessing the billing processes health, just a little bit of a check-in by looking at the different steps in the process. And I kind of think of this, I'm going head to toe, start to finish, however you want to look at that, but we're going to go from kind of beginning to end of the process and think through all of the different steps and actions at each phase that can ultimately impact whether or how you get reimbursed. So if we start very early on in the process, the point of scheduling, right, and collecting information from the patient, whether this is a live phone call to schedule an appointment, whether it's an online portal where patients are able to schedule appointments through a portal or some other electronic means, collecting some initial information about who our patient is, what their source of payment is and the reason for their visit or services might translate into whether and how we can deliver that service as telehealth, as an e-visit, whether it needs to be in person, whether the patient's eligible under their insurance plan for benefits, all at that initial step, and we'll walk through some of those pieces. Once scheduled, of course, we have either the check-in process, if we're talking about an in-person visit, or login, maybe if we're talking about a virtual or remote service, and the steps that are going to happen at that stage. We render the service, of course, we document the services that we've rendered, which then translate into what codes from diagnosis codes, procedure codes, place of service, modifiers, billing providers, all of these things that go from sort of the narrative description of what happened, translated onto the presentation of the claim form that's being submitted for reimbursement, entering those charges into the billing system, and then submitting them out for payment. Hopefully, we never have this step in the process where there are rejections or denials. That's one of the billing process health checks we're trying to prevent and avoid, but inevitably there will be some issues where claims are rejected by a clearinghouse, denied from the health plan that we have to work and address. That can also serve as a feedback loop to mitigate some steps or take action steps earlier in the process when we're seeing trends at this stage to avoid those or prevent them from happening in the future. We'll talk about payment posting. Hopefully it's always a payment rather than a denial, but when remittance advices come back, whether it's electronic or whether it's a manual process, some of the stages you can look at that step beyond just codes that you're assigning in the sense of a payment, a denial, or a rejection, but is the amount what we expected to receive? And if not, why not? And then one of the final stages in the process, once any third-party payer has adjudicated the claim and amounts are transferred to patient responsibility, we'll talk about some steps at that stage as well. So I'm going to go kind of, again, head to toe, start to finish, early on in the process when we're talking about just scheduling an appointment or scheduling a service. There's a lot of actions at this step that if you break it down, you can really see how this can impact either very positively or create some potential challenges in your billing practices and your realization rates for services. So early on in this process, we want to make sure we have steps to make sure we're verifying the identity of the patient. Even as the person in our family who is often scheduling appointments, it is sometimes confusing when you're filling out appointment requests. For my kids, for example, whether I need to be putting my own information in as the parent or guardian, or if a particular field is asking about my child who I'm scheduling the appointment for, or maybe a spouse, or maybe a parent or other family member. So making sure we're clearly identifying who the patient is in that process, and that impacts what chart we're assigning things to and who services get billed under, of course. We want to make sure we're accurately collecting some of that basic demographic information, the date of birth, the address, the legal name of the patient or as it appears on their insurance ID card. All of that we want to make sure we're getting as accurate as possible at this stage to make sure all of that information as it presents on the claim form will be accurate and reduce the likelihood of any rejections or denials because of data entry errors. I'm jumping ahead just a little bit, but I don't think I listed the specific example later on, and I thought of it as I'm speaking out loud, so I wanted to share one with you. I worked with a practice that was adopting a new electronic medical record system. And in that process, during the registration phase of creating an account for a patient or creating a new encounter for a patient, they developed a couple of manual processes as well as electronic safeguards at this phase to try to mitigate and prevent denials. One of those, if they were receiving an appointment request by phone, was a readback method, almost like a readback that you do with orders, to make sure the patient's name was spelled exactly as it appears on their insurance card. Any initials that appeared on their insurance card were input correctly. And then they created some electronic data mask, almost data entry limits for fields. For example, the first name field had to be in all capital letters. They didn't allow punctuation in certain fields. All of that so that when those fields translated to the claim form, they were translating in a way that was compliant with uniform billing standards and less likely to create rejections when the claim went to the payer. We also want to make sure we're collecting information at this step in the process about any third-party payers that might be responsible for the payment of services. This may be an opportunity to ensure you are reviewing and updating any insurance plan information, group numbers, ID numbers, whether the company and the specific product within that company may have changed from the last time you saw the patient. Sometimes practices only do this once a year. I recommend doing it at each appointment and either having the patient verify that there have been no changes or making sure that you're verifying all of the numbers and information remain the same. It's just for the time that it takes and the amount of denials or rejections it can prevent, a great practice to do that. Is that plan in network? That's something we may want to know for later on in the process as well. For different types of services, it may impact if they have an HMO, for example, whether they have any benefits at all through their plan, or if this will be full patient responsibility. This is also a great stage specifically for telehealth, to ask the patient where they will be when they receive this service. So they're scheduling an appointment, and if they're scheduling a telehealth appointment, a lot of times that is done through some kind of electronic questionnaire or electronic appointment request, and adding a field to say something like, provide the state from which you will be receiving this service, or having the patient confirm. If you're only located in one state, like the state of Kansas, you may want to ask, confirm that you will be in the state of Kansas at the time this service is rendered, yes or no. If there is an answer no, and you don't have providers licensed outside of that state, that might not be a service that is eligible to deliver as telehealth, because you don't have providers licensed in the state in which the patient is located at the time the service will be rendered. This is a really great way to have that double check from a licensing standpoint that you're all good to go when the service will actually be delivered. The reason for visit, of course, this will help translate into diagnosis codes eventually when we report the service on a claim form. So here's just, with each of these steps, I've provided a little bit of a checklist that you can take back and look at some of these questions and examine your own billing processes and practices to see if there's opportunity to expand on some of these steps and close any gaps that might actually be or have the potential to create rejection or denial or other reimbursement challenges for you. So have you reduced your scheduling process to writing? I have one organization I've worked with that every policy, every procedure, they write like a standard operating procedure, in the sense that If I had to go in and cover scheduling for that day, I could pull up that document and it has a step-by-step list so that anyone in theory could perform that function because every step is spelled out. But having that process in writing, if there are any variations, if a telehealth service is being requested, if there is any difference depending on whether someone is scheduling online versus calling in for an appointment, having that decision tree and those steps can be really helpful. Any checklist or script for the schedulers to follow. Really important then, if I go back one slide to help make sure we're hitting on each of these pieces each and every time a patient is scheduling an appointment. If there's a script, if there's a list of 1, 2, 3, 4 things every single time that has to be done, you're leaving less variation or opportunity for someone to forget to collect some of that information. Do schedulers, and this is referring more in the sense of when a patient is calling in to request an appointment that could potentially be delivered as an e-visit or as a telehealth service. Do they have a concept of what types of complaints or services may be eligible for telehealth? And one of the reasons that it's important to catch those early on is that if it's a condition or a complaint that really needs to be seen in person, you won't have the frustration of logging in, the provider and patient realizing really quickly this is not going to work as a telehealth visit. The patient has to come in person, and now you've got a longer delay to get the patient in and be seen. The frustration that surrounds that, the potential billing implications on do we not bill for a separate telehealth service, and just the patient relationship aspect can be helpful to have that delineated up front to get them to the right mode of delivery as quickly as possible. So then we're kind of approaching the time that the actual service is going to be delivered, either check-in or log-in, depending on the mode of delivery of the service. But there's a couple of things we want to do at this stage too. We want to make sure the person logging in is the patient that we believe we are seeing, right? That's a lot easier to do if you have an audio visual appointment and you have maybe an image from early in the registration process in your system, and you can visually compare, or it's a known patient, and so you know that person on the other end of the line is who you expect them to be. It can be harder in examples of new patients where there's maybe not that visual familiarity, or in audio only visits, or in e-visits where it's maybe asynchronous communications back and forth to somehow verify that the person you are evaluating and treating will be the person whose record is being documented on and whose third-party health insurance is being billed. At some point, we want to double check whether that's a checkbox, a radio button affirmation, a verbal affirmation, if we are providing a telehealth service, that the patient is located in a state that your provider, your rendering provider, is licensed in. That can be another stop point that if not, we're not able to render that service from a licensing viewpoint. If you have some of these steps created in sort of a questionnaire as the patient's logging in or during the scheduling process, it can be a great idea just to avoid having to replicate efforts, to have those sort of confirmations that the check-in process become part of the patient's medical record. And if there was ever any question about where the patient was located at the time of service, if they represented to you that they were in your state or a state that your provider's licensed in, but in fact they were not, you can show you asked the question and maintain that documentation and have that on file. So we want to make sure any pre-appointment registration, health plan information, demographic information, any clinical questionnaires have all been filled out by the time the service is actually rendered. And so I want to go through a couple of pieces here on the stage of actually delivering the service that might pertain more to telehealth services than in-person services. If you're arranging for a telehealth or telemedicine type visit and video isn't an option, it can be really challenging for a provider to know in real time Who's the patient's health plan? Does that health plan accept audio only services, and under what circumstances? And how does it change the billing code that we're going to use? But some of the most important pieces, if at that time video is not available, the functionality is not working, the patient doesn't want to use video for the service, documenting when it is not an audio visual interaction and why. There are some plans, Medicare, for example, as different waivers and flexibilities begin to expire, that will require, as we return to a default of audio-visual communication, that will expect to see why video was not used in a particular circumstance, even if you initially intended to use video. Having the patient's location documented, meaning if they're at home, or if this is a telehealth visit where the patient is at another originating site, like a clinic, like a hospital, like a skilled nursing facility. That is important, not just their geographic location or the state that they are located in, but their physical location of home, clinic, hospital, skilled nursing facility, because it will impact place of service coding when we translate that into a claim form for billing. And now there are plans, Medicare included, that actually pay different rates depending on whether the patient is presenting to a medical originating site versus being at home. Any consents. So this could be a consent form that you actually have the patient sign during the scheduling, the registration, or the check-in process. It could also be a verbal consent as you begin the service that, are you okay with proceeding as a telehealth visit? Are you in a quiet place? Are you in a good place and time for this service? And quickly documenting yes within the progress note. Consider documenting the duration of the telehealth service. Even when the codes that you typically would choose may not be time-based, there might be a lot of circumstances in which the billing code that you ultimately send out to a third-party plan has to change. For example, if you intended an audio-visual visit that would have been billed with as an evaluation and management service where time isn't necessarily required, but for various reasons, video wasn't working, and now we have to bill that as an audio-only telehealth visit, those are time-based codes. And if you don't have the time documented, you would be limited to the lowest duration of time when you bill for that service. So even if the provider isn't initially planning on billing a level of service based on time, it can still be a good idea and a good practice to document the duration of a telehealth visit in the event coding changes have to happen later on. Of course, we always want to make sure, whether we're telehealth, whether we're in person, that the documentation is created in a timely manner. I give the example of 48 hours. There's different suggestions, and depending on your provider type, hospital, community mental health center, clinic, skilled nursing facility, there might be different regulatory timeframes. But there is a broader principle under programs like Medicare that medical records be created promptly. And I mean, we're Kansas, Missouri, if you have WPS as your MAC, there is a page on their website. So this is not binding, but it is highly indicative of what they would consider timely, to be within 24 to 48 hours of the service. And then, of course, authenticating or signing off on the note following all valid signature requirements. Quick checklist for just general billing practice health at this stage of rendering the service and making sure we have all of our documentation put together. Do you have something like a missing ticket report? Missing ticket coming from when we quite literally had your checkout sheets where the providers, circled procedures and checked different billing diagnoses, and any tickets that were missing a corresponding bill we could reconcile. Same concept when you're using electronic medical record documentation and billing systems. Are there services, are there encounters missing a ticket, a bill that corresponds with that encounter? And if so, why? Is it because there was not a note documented? Is it because we're waiting on information from the patient? The note has to be signed. What was missing to translate that service to a bill? Do you run any unsigned note reports? I've seen practices that have their medical record and billing system set up to not allow claims to go out until notes are in final status. And notes don't go in final status until they have been signed or authenticated by the responsible provider. So unsigned notes can create challenges on untimely documentation, but can also create challenges in literally preventing claims from going out the door to be considered for reimbursement. If we let those go on too long, we have a potential issue with plans not wanting to accept that documentation for being documented untimely, and or timely filing limits with our health plans that we could run up against if we don't get those finished on time. If there's any coverage policy for the services that you are providing, any national coverage determination from Medicare, local coverage determination, things like that. Psychotherapy can be an example of one that nationally or locally, there may be coverage policies describing when and how those services are covered, the qualifications of providers who can deliver those services, the frequency at which Medicare will cover those services. In those circumstances, we may also want to ensure that we are getting an advance beneficiary notice from Medicare patients. This might be at the stage of rendering the service. It could also be earlier on in the process of registration and check-in, depending on the chief complaint that the patient is entering and how that translates into what service may be provided. Are there any other special forms that are required? For example, different Medicaid forms might have healthy child and youth forms for preventive visits. If this is a visit to discuss the possibility of a sterilization procedure, Medicaid, other plans may have specific forms that have to be used as a consent 30 or more days in advance of that procedure that we may want to provide to the patient. So any special forms based on the patient's services and health plans, this is the time to make sure we have those in order. Then we render the service, then we want to capture the charges. So this is not quite at the stage of putting it on a claim paper or electronic claim form and sending it out yet, but are we accurately and comprehensively capturing all of the services that were rendered? And when I say capture, that could be something as basic as the missing ticket or the missing encounter. We had a service, no charges went out. But it can also be even more detailed than that. Within the encounter, have we captured all the items and services rendered? For example, if we are rendering a telehealth visit where an evaluation and management service has been rendered, there might be additional codes. G2211 is a new code a lot of providers are talking about in 2024. It is an add-on code for a lot of evaluation and management services by primary care providers or certain specialists under certain circumstances that can add a payment on to your evaluation and management code. Depression screening, alcohol screening, any other services that might have been rendered as part of that visit. We want to make sure we're capturing those, all of them, to be able to translate onto the claim form. Advanced care planning is a common one that is a discussion-based service that may be rendered in addition to an evaluation and management visit, often missed. Annual wellness visits for patients with Medicare, prolonged services, particularly applicable if we have documented our time during the evaluation and management service. And then we want to take those charges we've captured and make sure they all get appropriately entered onto the claim form. Lots of different opportunities for issues and errors in this process. And this is really more of a technical process. So we might be reporting the wrong procedure code. Medicare has a lot of program-specific codes, HCPCS codes that start with a letter like a G, where other plans may want the CPT code version of that exact same item or service. Depression screening, tobacco use cessation counseling, alcohol screening, those types of things have both a HCPCS code and a CPT code. Depending on the third-party payer, it might dictate which of those codes actually go on to the claim form. Wrong diagnosis codes. This can happen in several different ways as you prepare the claim to be submitted. That can be literally a typo on the code that you report, so transposing numbers. It could be a matter of linking the wrong diagnosis to a procedure. Give you an example of this from several years ago. I had a practice that I actually worked for at the time. And we identified a sudden surge in denials for lipid profiles and as non-covered services. And we started to dig into why we suddenly started to receive these denials. And we realized we had a new coder at a new location that was not linking the lipid profile to the correct diagnosis. She was always linking it to whatever was the first listed diagnosis on the claim. So otitis media, things that are completely unrelated to lipids and cholesterols were getting linked to that procedure. So we were able to create some edits to stop that from happening, to do some education and intervene, and immediately saw a quick drop in denials and quick increase in revenue for those services. The number of units that we're reporting. I'll use therapy as an example because I think PT, OT, their therapy units can become some of the most complicated time-based units to report. For example, are we dealing with codes where there's a minimum threshold that has to be passed? 15 minutes, 30 minutes. Or is there a midpoint rule involved? For example, a code whose description says 15 minutes, but CPT says as long as we pass the midpoint, 7 minutes and 30 seconds, if I did my math correctly, we could report that code still, and making sure we get the correct number of units based on the codes reported. Place of service billing, see, I didn't list it specifically here, but it's another area, particularly in telehealth, that has undergone a lot of changes in the last 3 to 4 years. During the public health emergency, we were allowed for most payers to take place of service code 02, a telehealth service, and instead use the place of service we would have reported if that telehealth service had been rendered in person. And that allowed us in many circumstances to capture increased reimbursement for non-facility settings. Like if that was substituting for a clinic visit, we could get a higher non-facility rate of payment. Some of those place of service billing policies have changed. They've changed for Medicare, and they are at various stages of changing for different private payer plans. Now, most payers are again wanting place of service 02 for a telehealth service. But in the middle of the pandemic, a brand new place of service code 10 was created to also describe telehealth services. And place of service 10 is used for telehealth rendered to a patient at home or other private residence, where 02 is now anywhere but home. Medicare allows place of service 10 to be paid at a higher non-facility rate of reimbursement as opposed to 2. And making sure we get the right one when we can translate into optimizing the reimbursement accurately versus missing out on reimbursement if we're not using the correct place of service code. Private payers are at different stages of adopting place of service 10 as well, and whether or not they will also adopt the higher rate of payment. So we have to stay on top of our private payer policies in that respect as well. So all of these are different places at the claim, the billing stage that you can examine to make sure you're getting those technical pieces correct as you're presenting the claim. So claim goes out the door. We hope you're paid the first time and accurately, and you never have any rejections and denials, but the reality is they happen, right? So here are some steps in that process that you can kind of look at your procedures and see, are we doing this? How well are we doing this? And what could we potentially do better for our billing practices? When I say rejection, I'm referring to a claim that goes out your door and has to pass through a clearinghouse or some scrubber before it gets to the health plan. When it gets to the health plan, if it makes it through the scrubber, the health plan then either pays or denies the claim. So the rejection would be kind of at that intermediary stage. It doesn't ever make it to the health plan. So those, whether it's your scrubber or a formal clearinghouse, need to work those rejections quickly to make sure we're not creating timely filing issues that, once corrected and sent back out and passed through the scrubber or the clearinghouse, they get to the health plan would say, nope, you waited too long, it's outside of your timely filing limit, we will deny coverage and payment. So we need to make sure we're working rejections, but also trending rejections. Why are they getting rejected at the scrubber or the clearinghouse? And if we start to see the same issue over and over, we want to go back to earlier steps in the process. Do we need to capture something at scheduling that we're not capturing? Do we need to implement an eligibility verification process? Do we need whatever that step is to prevent those rejection trends? It's important to keep in mind that when you send a claim out and it is rejected at the clearinghouse or the scrubber level, the plan has not received that claim yet. So if you think about prompt payment rules, timely filing rules, you have not preserved your timely filing and prompt payment yet if it hasn't made it to the plan, because those rules are often written by the date of the plan's receipt. So we've got to get it through this stage and get it to the door of the health plan to be received and adjudicated there. If we get rejections or denials back from our clearinghouse or from the health plan, consider, when possible, identifying why that claim was denied, the actual denial code on the rejection or on the denial. Is it ineligibility for coverage? That means the patient potentially didn't give us the right insurance card, or we didn't get updated insurance information, or their coverage ended maybe between scheduling or the time of service. Is it a non-covered service? Is it a missing or invalid diagnosis? That allows you to track, to trend, to root cause, to fix, and then to prevent those issues from recurring again. And every time you're able to put in an extra step or a prevention mechanism, you're going to reduce those rejections, reduce those denials, and improve the time frame in which you receive payment and accurate payment. If you don't agree with the denial or the rejection, evaluate whether you want and want to exercise your right to appeal denials rather than necessarily accepting a denial, writing off the balance, and moving on to the next claim. Some of the steps in that process might involve a dollar amount that you really closely examine denials, or trending even small dollar amounts across plans can add up to a very large amount. So it may not be an individual claim number, dollar amount number, but an issue type that you start to examine whether or not to appeal those. And then we hope you get payment posted quickly, accurately the first time around. But here's some options during the payment posting process. Often this may be done on an automated basis as electronic remittance devices come into your organization. If that is an automatic process, consider also making sure contractual write-offs are periodically reviewed. And what I mean by that is there's a difference between a denial and a write-off, right? So a denial is a health plan saying, it's a non-covered service, the patient's not eligible for benefits, there's a coordination of benefit issue, we are denying payment. But a contractual write-off means there is something contractual between you and the plan that disallows certain amounts from being considered for coverage and payment. If you bill $500 for a service and you have negotiated with a health plan to be paid $400 for that service, $100 is a contractual write-off, not a denial. But you want to watch those closely, because sometimes what really should be a denial comes through automatically as an adjustment. And it may not trigger anyone to look at it. We don't typically look at that $100 because we know and we expect that amount to be reduced from our original charge. An example, had an organization that looked at contractual adjustments where the amount adjusted equaled the billed charge. Because if a plan is contractually adjusting the entire amount off, that organization suspected that might actually represent a denial, not a contractual adjustment. That report led to an investigation that helped them respond to certain, I'll call them denials, non-payments through appeals. So do you receive payment timely? What is the time frame that this payment is coming in compared to the date the claim was received by the insurance company? Depending on your state, depending on your contract, depending on prompt payment rules that you've negotiated with health plans, interest can be incredibly important to be tracking and holding plans accountable for. Give you an example. It's not in one of my examples that I listed in the echo, but I keep thinking of instances as I'm talking out loud. I had an instance of a claim that took 5 months for the plan to pay. And I'm trying to think, it was about $30,000 that the organization expected to receive in payment. Under the particular state that that organization was located in, there were very healthy prompt payment, interest, and penalty laws to protect healthcare providers. And there was no denial. There was no request for additional information. It just took 5 months for the health plan to pay. Because the plan was subject to those interest and penalty rules in that particular instance, the amount of interest and penalties exceeded the $30,000 that the organization was even expecting. So they ultimately were able to recover more than $75,000 on that claim, where originally they were only expecting $30,000 to begin with. So prompt payment, interest penalties can be very important for your practice to have an eye on, especially if you know that it's a problem with certain plans. Ensuring the accuracy of the payment amount can be very important as well. And this can get tricky because your contracted rate, and I'll use $400 again as an example, may not necessarily equal what you get paid from the health plan, right? Because we have copays, we have deductibles, we have co-insurance, where the patient may be responsible for a portion of that allowable amount. If you have a system sophisticated enough to determine, based on that patient's eligibility and benefits, what the plan should pay versus what the patient should pay, great. But if you can also evaluate, by the time you get to sort of a zero balance on accounts, did your total payment equal the amount you were expecting under your particular contract? If it's below, we want to figure out why. Do we have patients not paying their portion? Do we have the plan not paying their portion? What's the source? And we can sort of work backwards to try to rectify that. And then one of the last stages in the billing practices process are having mechanisms to send statements out to patients timely. So once we have a primary and or secondary payer that adjudicates the claim. We want to get that out to the patient as quickly as possible. Nobody, whether we're the patient, the consumer, the provider, no one likes to get a bill 9 months or a year after a service has been provided. Patients are no different. We want to get that to them, and it increases the likelihood that they pay that bill promptly, as opposed to letting it sit. So I want to just very briefly go through a couple of key performance indicators that you can think about. There's all sorts of KPIs in your billing practices. If you choose to track and follow any KPIs, it can be very practice specific to your types of services, maybe where you know you already have challenges and you want sort of a performance improvement project to reduce denials or rejection or improve payments in a particular area. But a few to think about might be understanding your payer mix, your portion of traditional Medicare, Medicare Advantage, combined Medicare, which is traditional plus MA, your Medicaid portion, your commercial portions. That really can help dictate how you drive some of these processes. And if you want to use Medicare rules as a default, because 75% of your payer mix is Medicare, versus maybe commercial is your primary payer mix. And so you may not want to, by default, use Medicare rules on a lot of your coding and billing processes, because that might not apply to the majority of your claims. Wrong payer rejections. These are kind of like a coordination of benefits or a denial because a patient's not eligible under a plan. That might indicate a problem at the scheduling and the registration stages, that we're not getting updated insurance information, accurate information, typos in putting that information into the system. We're not double checking when the patient gives us their card to look at the system and the data that's been entered to make sure all of those are exactly correct. Your initial denial rate and final denial rate. We might get a lot of rejections and a lot of denials initially, but we're able to work through those and eventually get paid. That's great, but we spend a lot of time and resources on initial denials. And so we want to see what can we do to prevent those, fix them not only on individual claims, but earlier on at the previous steps in the process. And if we have very high initial denials, very low final denials, that can mean a couple of things at the initial denial or rejection stage. We have processes within the organization that can be addressed, or we might have payers and plans that have some claim adjudication issues that we need to coordinate with to get addressed as well. If both initial and final denials are very high, that can mean the same combination of payer and internal issues, but it also might be indicative that there's not enough resources to work those denials, to get them appealed and to get them fixed, to realize and to collect on the payment on those issues. Days in AR is another really common one that most of you may already be familiar with. Of course, the longer accounts sit in accounts receivable, the less likely we are to collect on those. In a managed care contracting role too, days in AR is important to me, not just from how revenue cycle is doing, but there might be certain plans where the delay in payment or the administrative burden of going through the appeal process or how long the appeal process takes might be creating a shift in our AR to have accounts sitting there longer than they otherwise would for other plans. And I can say, payer A, your days in AR are significantly more on average than every other plan that's averaging here on our days in AR. And that can be a contracting discussion as well. So let me go through a couple of case examples for each of these stages in the process. I've mentioned a few as I was going through the presentation. One is specific to telehealth, an online questionnaire that helps triage chief complaints to determine if they are appropriate for a telehealth type visit. So I've done this with my kids several times. I go to the healthcare provider's website to schedule an appointment, and I'm given the option. Do you want to come in person, or would you prefer a telehealth visit? So that's sort of decision tree number one. I love telehealth, so I might choose a telehealth appointment. And if I choose that option, rather than just assuming and moving forward with booking a telehealth appointment, I'm sent down a decision tree of what the symptoms are, if they're respiratory, has the patient tested positive for COVID in the last 14 days. But there's all these questions that kind of help determine, is this a discrete, a well-defined acute issue that is appropriate for telehealth, or certain responses that might suggest I need to come in person. So I don't waste my time logging into a telehealth visit that ultimately I need to come into the clinic for. Intake of health plan information, it's scheduling. I've had a provider that used this process where the patient inputs their insurance information. So we don't necessarily have them take a picture of their card, although I have seen places do that as well, in addition to manually inputting the information. But with that information that comes back, Richelle Marting, Health Plan A, number 12345, and through either an automated process or manual process, they can verify my eligibility for benefits under that plan. It's an active plan. I am covered by that plan, and my coverage is scheduled to continue at least through the date of service, so that we don't have a change in plan between now and my visit. That eligibility checking can just be so incredibly helpful to make sure you are getting the right plan at registration the first time. In the charge capture process, a great way that I have seen providers capture those additional service, not just the office visit, but advanced care planning, vaccines, even depression screening, those types of services that are happening during an evaluation and management visit, are to do that through orders. So the provider orders advanced care planning, the provider orders depression screening, marks it complete just like they would for lab testing or for imaging or to perform a procedure during a visit. Those completed orders in the system do several things. They help us track frequency. If we need to do that depression screening once a year or once every however often, it can be scheduled to pop up again and remind the provider it's time for the depression screening again. It's time for the Medicare annual wellness visit again. Prompt them to complete it, mark it complete, and then that creates a reportable field where we can make sure we're capturing those charges. At the charge entry process, telehealth in particular, with all of the changes to the telehealth modifiers, place of service codes, services that are or not eligible for telehealth reimbursement under Medicare, when they became ineligible for reimbursement, whether they can be rendered by audio visual, audio only, or some other format, qualified distant site practitioners, all of those variables in telehealth are hard to keep track of. So I've had a medical practice create a matrix by payer that lists what place of service code, whether they do or do not want a modifier 95 to identify a telehealth service. If they have any limits on distant site providers, if they have preferences on different billing codes, and use that tool to create some billing process logic in their system, or manual entry for coders and billers to visually look at and make sure they're getting those details correct before a claim goes out. On the back end, there are more and more tools available to help examine the payments that you're receiving compared to the contracts that your organization has negotiated to make sure they're accurate. And you might be surprised, you might not, on how prevalent it is for them to not match up. That might indicate there's been a change to the fee schedule from your health plan that you don't have a copy of. You want a copy of that. It might indicate underpayments. It might indicate overpayments that you can detect early before it accumulates to a large amount and a large refund request with the plan. So those tools can be incredibly helpful to assess the accuracy of your payments in real time. So I'm going to pause there because I know I want to leave time for questions or comments, and we've got just a few minutes left before the top of the hour.
Thank you again, Richelle. What a great, robust presentation you had. Just a couple of reminders, and we'll watch the chat to make sure there's no questions that come in. We will be sending our follow-up email with any materials, including the recording, to those of you that registered today, and we will be sharing it on our YouTube channel as well. Please be sure to check out, you should already have the dates in your inbox if you've registered, but we will be sending out calendar invitations for our July 9th ECHO, focused on using AI in the clinical setting, primarily with virtual notes and things like that. August 13th, we will be presenting on practical tools to avoid digital burnout. And you can always email us for questions. For those of you that would like a certificate, please send us an email requesting that. We'll get that to you as soon as possible. And we have noted you in our chat that we will be sending off those certificates of attendance as well. So I will open it to any questions for Richelle. We've got 3 minutes. Otherwise, thank you all for attending, and don't hesitate to reach out if you have any questions.